Well, thank you for inviting me. Thank you to Dr. Gordon and to Dr. Hansen. I appreciate the invitation. I'm really excited to be able to talk to you about some of the things that we are already able to do with cancer patients in the clinic. All of this is a work in progress. I don't want any of you to think that we have a cure for cancer that's based on diet. We absolutely do not. But there are some hints about what we can do to potentiate our cancer therapies today. And as you know, there are 8 hallmarks of cancer. There used to be 6, now there are 8. And they have to do with things like growth inhibition, absence of cell death programming, things like that. The 2 new ones that were just added in the past few years, well, the one new one that I want to talk about here is metabolic derangement. And that's one of the new hallmarks of cancer. So that's what we're going to be talking about today. All cancers have some of the 8 characteristics to a certain extent. Different characteristics are emphasized in different cancers. There are very few that have just one derangement. The one that you will be familiar with is chronic myelocytic leukemia, which is treated by one drug, a kinase inhibitor called Glycemic. Diet has no effect on it, nothing else has any effect on it, but luckily that one particular defect can be targeted with a drug. Other cancers are typically, the more common cancers are very, very metabolically complex. For instance, pancreatic cancer, in contrast to chronic myelocytic leukemia, has 12 different recognized derangements, not counting all of the idiosyncratic ones that you would find within one patient's tumor. So having said that, cancers are often metabolically inflexible. And what does that mean? It means that they can't use all sorts of fuels really easily. Doesn't mean that they can't use them at all, but it means that it's difficult for them compared to normal cells in general. And this, again, is not true across the board, and I want you to keep that in mind. But metabolic flexibility has to do with the ability to use different fuels in different situations, depending on the fuel availability and the needs of the particular tissue and organism. So what we like to think about in major common cancers is the inability to burn fat. And you have patients coming to you saying, my cancers eat sugar, and this is what they mean. It's not that they eat sugar, everything eats sugar, but they're unable, and that's what you need to remember, they're unable to utilize fat as a fuel. So here's a PET scan in a normal patient. And what I want you to notice here is that there's a lot of uptake. These 2 organs here are the kidneys, and there's a lot of uptake here because there's a lot of blood, and it's getting rid of the glucose solution, and this is the bladder. So those are normal processes, and the kidneys are supposed to light up. There's a lot of blood in the heart. This is the heart here. There's quite a bit of blood in the kidney and the liver and the spleen here. So this is what a normal PET scan looks like. This is a PET scan in a patient with early breast cancer, and you see the tumor in the breast here. You see some uptake in the kidneys as they drain the fluorodeoxyglucose from the bloodstream. You see the primary tumor here, and it's pretty dramatic. There may be a hint of an axillary or a subclavian lymph node here that's also positive. This uptake in the jaw area is normal. This is what you want to prevent in cancer. This is a patient on your left here with a lot of different tumors involving the liver, the axillary lymph nodes, some of the thoracic and cervical lymph nodes, lymph node chains in the pelvis and groin. This is the same patient after therapy. Things are much, much better. I just give you this to lead into what is a PET scan. A PET scan is a picture of sugar metabolism. All right, so if I go back here and tell you that, it's starting to make a lot of sense when we start talking about cancer. You're looking at, in a PET scan, a picture of sugar metabolism. There are new types of PET scanning that don't use sugar. They use things like particular amino acids. Methionine is one. Leucine and isoleucine are other ones. And you can get pictures of cancers using those types of molecular imaging studies, they're called. So it's not just that cancers utilize glucose and that's it. They also like some other nutrients, and we have to think about those. Glutamine is one. We'll talk about that a little bit later. So this is a what we call a kind of a bread and butter. I know this is a gluten-free crowd, but this is a bread and butter breast cancer case. Okay, a postmenopausal woman. And postmenopausal breast cancer doesn't mean somebody who is now postmenopausal who was diagnosed with breast cancer at some point in their life. Postmenopausal breast cancer is a very specific diagnosis. It means breast cancer that's diagnosed at least 1 year after your last menstrual period, so in true menopause. So stage 2, hormone positive, very common presentation. Very common for these patients to be somewhat overweight or even obese. Very common for them to be have less than their 150 minutes per week of exercise, as Daryl talked about. And they often have had a lifelong struggle with weight, especially since adulthood. Now, childhood obesity actually is protective against breast cancer. We don't understand that. It will be up to us and to you to figure that out. Thank you. But weight gain after adulthood is dangerous in terms of breast cancer risk. And this patient continues to gain weight. She's even gotten a little bit heavier after her diagnosis. So what can you tell her? She comes in, and patients will say, you know, help me. I don't know what to eat. I've got cancer. I know it has something to do with it. What should I do? So what do you tell this patient? You know, we have in the past 20 years told them, well, you should eat lots of fruits and vegetables. You should, you know, increase your fiber. All of those things have not panned out. All right. Now you can find some observational studies that will find maybe in this population a little bit better cancer statistic than you know, with fruits and vegetables than without, but they're inconsistent and they're weak. Here's a very, very powerful study. It's breast cancer survival and carbohydrate intake, and this is from a subcohort taken from a prospective trial that was an interventional trial, very ambitious, low fat, high produce. The patients were in this trial all had early stage breast cancer, that's stages 1 through 3, and they were admitted to the trial within a year or two of diagnosis, and they were followed for up to 8 years. Average, I think, was 5-point-something years of follow-up. And there was no benefit to these patients to following a high produce diet. And it was a lot. It was high fiber, low fat, 20 grams of fat or less was the goal. Nobody achieved that, but that was the goal. Between 6 and 12 servings of fruits and vegetables a day. And the researchers, not the patients, but the researchers were maniacs. They were actually measuring the carotenoid levels in the blood of these patients to make sure they were, you know, eating their vegetables and things like that. So when you took a look at, these were patients of all ages, when you took a look at patients just who were postmenopausal and who had estrogen receptor positive tumors, if you decreased their carbohydrate intake by 27 grams a day, you halved the hazard ratio of recurrence. Okay, I want to just let that sink in for a minute. Now, this effect was seen only if the breast tumor expressed a receptor for IGF-1, and about half of the breast tumors in this particular sample did. What was very interesting was 40% of Caucasians had tumors that expressed this, 80% of Hispanics, and 90% of African Americans. Now, there were very few African Americans. I think there were 13 in this study, which comprised, I think around 300 subjects altogether. So we can't really say too much about that, but I just give you that to let you think about that. So what's 30 grams of carbohydrate a day? This is what we're talking about. This was how much they had to decrease their carbohydrate intake after diagnosis to gain this benefit. These were not paleo heads, okay? These were, you know, this is a very modest decrease. So now I want to talk about this, and this was what I pulled out when I really wanted to come here, and I sent Rick, I think I sent you this slide, and I said, I got to come and talk to you folks, because this, well, let's just take a look here. So if you give older patients. Now, this is not all comers with breast cancer. This is older patients, 50 to 69. I would have chosen strictly postmenopausal, but the statistics weren't developed that way. But from 50 to 69, most of these people are going to be postmenopausal at diagnosis. If you give them chemotherapy, you decrease their mortality over 15 years by about 20%. Okay, not bad, that's good. If you give them tamoxifen only, you decrease their mortality by 31%. If you put the two together, you get a nice 45% decrease in breast cancer-related mortality. And again, this is over 15 years. If you give them one less banana a day, okay, you get a 40% decrease in the hazard ratio. Now, I want to say that we're mixing, I'm talking about bananas, we're mixing apples and oranges here when we're talking about mortality decreases and chemotherapy in 15 years and bananas in an observational study and a 40% decrease in a hazard ratio, which is a statistic that has to do with the instantaneous decrease in your risk at any one point, okay? And we're talking about over 5 years instead of over 15 years. And breast cancer statistics do not level off after 5 years. You keep seeing recurrences in a kind of a linear fashion as long as you keep looking. So again, but I want to say that anything that looks like this in oncology is whopping. We usually talk about 3% improvements overall with chemotherapy and things like that. So this is impressive. So I want to point out that the people in the study here, the carbohydrate decrease cohort, also were treated with chemotherapy and tamoxifen. They weren't just told to go home and cut their carbohydrates. And in fact, they weren't told to cut their carbohydrates at all. They were told to take all these fruits and vegetables in. Even in the IGF-1 receptor positive tumors, there were differing levels of expression. So they scored them 3+, 2+, or 1+. You've seen those kinds of things in pathology reports. So we don't know exactly what that means. Was it, if you have a 3+ change, is that better than a 1+? We think yes, but we don't know. And again, the hazard ratio at 5 years is difficult to compare to mortality at 15 years. So that's breast cancer. So that's what you can tell your breast cancer patients, stage 2 postmenopausal breast cancer patients that are have tumors that are hormone receptor positive. Cut your carbs, okay? You don't have to go keto. You don't even have to go paleo. You have to leave off some of those bananas and things, okay? So carbohydrate intake actually affects colon cancer survival. This is from a study published by an epidemiology group out of Harvard. They followed colon cancer patients for many years, and they dissected their diet and lifestyle every which way you can possibly imagine. They looked at fiber, they looked at the standard American diet, they looked at meat intake, they looked at exercise in a different study. The only thing, exercise did pan out, but the only thing that panned out really powerfully in stage 3 colon cancer was the daily glycemic load. That was how they measured carbohydrate intake in this population. I don't really like glycemic load. I think it's for patients, I think it's kind of clumsy for people to be trying to figure out their glycemic load, and it obviously varies between people. But the take home from this is that there was a big difference in mortality. Okay, the gold standard in oncology is mortality. Are your patients alive at a certain length after a certain length of time from colon cancer with decreased glycemic load? There was a big caveat in this, though, and that was only if the patients were overweight or obese. The thin patients got no benefit from this particular carbohydrate level. So that's interesting. So we talked this morning, Jeffrey talked about insulin, and insulin is well known as a growth factor in oncology. We try to get our patients' insulin levels as low as possible. We don't know how to measure them. Do we measure fasting insulin? Do we measure postprandial insulin? Insulin is difficult to measure. The patient has to go to the lab. People are working on metformin, and that seems to be helpful in patients who already have diabetes in observational studies, and randomized trials in the adjuvant setting are in progress, meaning in patients without diabetes who just happen to have cancers that may be related to insulin, we're giving them metformin and seeing what happens. Does it help? So your patients will come in and say, well, what should I do? You know, I know that, you know, food and exercise and everything has something to do with cancer recurrence. Should I lose weight? Should I check my, you know, they don't come in and say, should I check my glucose or insulin levels? But I'm asking you that. And the answer is, really we want to change that, but our proxy, as imperfect as it is, because again, insulin will go up before glucose goes up, is the glucose levels, because the patients can check it at home. And in my practice, my patients are checking their glucose at home. And I have them check postprandial glucose. I have them check morning glucose. And this is very instructive and eye-opening to patients to see, boy, this food, this particular meal really made my glucose go up, and this other meal didn't. So some other things that we won't go too much into that are important, though, and I just want to touch upon them, is that you certainly can be insulin resistant and have normal weight, all right? And you can be obese and not be insulin resistant. Those are all, you all know that. The microbiome has a lot to do with insulin resistance, obesity, cancer, and appetite. There are environmental processes that can change the insulin environment and other things. And then stress and cortisol, of course. So we'll talk a little bit about the microbiome. Germ-free mice, give them a high-fat diet, and they're not obese and they're not insulin resistant. Now these mice are not on a paleo diet, okay? They're on Purina, you know, obesity chow, but you know, which has a lot of grains and things in it besides fat. But in any case, you transfer the microbiome from an obese mouse into a lean mouse, and the lean mouse will gain weight. And this will occur even if you cut their rations. So this happens in humans too. You can do a fecal transplant. We do need a new term for that. If you come up with one, let me know. If you take a transplant from a lean, healthy donor and put it into an insulin-resistant human being, the formerly insulin-resistant human being will become more insulin sensitive. Unfortunately, the effect is temporary, 8 to 12 weeks, and that's because changes in the microbiome, permanent changes in the microbiome, we haven't figured out how to do that yet. So you've heard of this gentleman, Thomas Seyfried, who's written a book, and that's a lead into a very, very popular topic among your patients. They will come in and say, I want to go on the ketogenic diet. I have been diagnosed with cancer, and this cures cancer. So let's talk about this. So let's take a pretty a patient who's almost certainly going to come in and say this. This is a middle-aged man with a very, very high-grade brain tumor, glioblastoma multiforme, as bad as it gets. He's already had the tumor removed, or as much of it removed as possible. He's had radiation. He's had chemotherapy. It's still getting worse, okay? So what's his 5-year survival? What can I do for him? So you're not going to tell this patient, no, you can't go on a ketogenic diet. I mean, you're not going to say that to them. So the ketogenic diet, I must say, has never cured a glioblastoma, all right? At least not in the medical literature. There are series that show that it extends, it has shown some benefit and has held disease steady. The amount of time that seems to be is about 6 weeks. It's not a long period of time, but there's not no effect, okay? So there are cancer treatments that we give patients that are worse than that in terms of their efficacy. So 6 weeks of stable disease, possibly. So what's the ketogenic diet? It's basically a diet that gets you into ketosis, and you will see people give you different ratios. I put this one up. This is one that might work for some people. But the way to know if you're on a ketogenic diet is to check your ketone levels. That's it, all right? So again, the proposed mechanism is that there's a decrease in insulin, and insulin is a growth factor. It tells tumors to grow. a decrease in glucose, so you're depriving the glioblastoma cells of their preferred fuel. And ketogenic diet may have something to do with IGF-1, although this is controversial and we don't know the direction yet. So that, stay tuned and we'll have more about that. So I think you all know about this. The ketogenic diet was first developed for pediatric epilepsy patients. There may be a differential in the use of glucose and fat in normal versus malignant brain cells, although it turns out that only about a quarter of glioblastoma multiformes may be sensitive to this dietary maneuver. So there are 14 open studies of ketogenic diet and cancer right now in the world. Most of them are feasibility studies. In other words, can we get our patients into ketosis and keep them there for long enough to do anything? Most of them are adjuvant. In fact, all of them are adjuvant. They're combined with other studies. Nobody's doing this as the sole treatment for cancer. 6 of these 14 studies are in glioblastoma patients only. The rest of the studies are in some other tumors. Many of these, in fact, most of these are also using calorie restriction as part of the ketogenic diet. So here's a ketogenic diet meal. You need support. You need a coach, and most people need a coach and some equipment, and lots of friendly input from their family. This is a ketone meter that I'm sure many of you have. So I mentioned before that cancers can be addicted to other energy sources and other nutrients. Glutamine is a big one. Most cancers can use glutamine in the same way that they use glucose. So we used to like to give, in the alternative and complementary world, glutamine to patients especially who are on chemotherapy, because it does help protect the gut from the chemotherapy effects. However, it also is a very, very necessary and dangerous ingredient in terms of tumor growth. So we don't recommend it. There have been no studies that show that glutamine, when given to chemotherapy patients, improves survival. In fact, there's one study that purports to show this that actually proves the opposite. So here are some other things. Branched chain amino acids, leucine, isoleucine may be important as fuel sources and in some tumors. So let's talk a little bit about chronic caloric restriction and fasting. So we know that, how much time do I have? Are we doing okay here? Okay.
20 minutes.
Okay, all right, thank you. So we'll talk about this then. Chronic caloric restriction has a very long history, as many of you know, in delaying and preventing diseases of aging. And these are in several systems: neurologic, rheumatologic, malignant. In all organisms studied so far, the lifespan has been extended, and this goes across several kingdoms. Underweight can be a problem in oncology, and it can be a problem in chronic caloric restriction in animals as well. So by chronic caloric restriction, we're talking about cutting the daily caloric intake from 20 to 40% based on ad libitum intake. So intermittent fasting seems to be a little bit more powerful in some studies in terms of enhancing longevity. One of the nice things about it is that animals that are fasted intermittently, a common scenario is every other day feeding, make up for their caloric decreases on the days that they do eat, and they're not underweight. It also rejuvenates the immune function. And in cancer, one of the most interesting things is that intermittent fasting sensitizes tumor cells to drugs. So what does that mean? That would be fine as long as it doesn't sensitize normal cells, and indeed it does not. So normal cells actually do a little bit better in terms of chemotherapy side effects if the patient is fasting, or if the animal is fasting. IGF-1, which can be a growth factor for many tumors, is decreased. Insulin resistance is decreased. So I'm going to show you a couple of slides that I think are going to rock your world. right? So this is a mouse model of human melanoma. And what that means is that these are mice bred to accept the injection of human cancer cells and not reject them. All right, so these are immunosuppressed mice, and this is a common model used in oncologic research. So these mice are all the same. They're all injected with melanoma cells from one human being, okay? So again, this is not something that you can take and generalize very much from, but I still think you'll find this quite fascinating, or at least I did. These are the mice that were not given any treatment. These are the mice that were fasted. These are the mice that were given DXR, that stands for doxorubicin. You will have heard of this drug. It's adriamycin. It's a commonly used drug in breast cancer therapy and in humans. And this is the group that was given adriamycin and also fasted. So along the y-axis, we have the number of organs with metastases. So they sacrificed the mice at a certain period of time all at once and counted up the organs that had metastatic deposits in them. The most were the mice that were not treated with anything. Well, no surprise there, or let's hope that's not a surprise. The second best were the mice treated with chemotherapy alone. The third best, this is the rock your world part, okay, were the mice that were fasted, okay, and the ones that were fasted and got chemotherapy did the best of all. So let's look at this in a different way. So this is, again, we're talking about survival. That's the gold standard in all of medicine, and usually a good survival, okay? So here is the percent survival. They're all alive at time 0, and this is the time along here, and this is days, okay? So they're all injected. All the mice are injected with the melanoma cells here, and they go along in their little mouse lives until day 18, and then half of them are fasted, okay? And at day 20, half of them, some that are fasted and some that are not, are given doxorubicin. So we have these, we've just generated these 4 groups. Are you all with me here? Okay. So let's see what happens to these groups. Well, this is a survival curve. This is a Kaplan-Meier curve where they have these stair-stepping, the stairs of death, I call them. And you see that everybody pretty much dies at between day 35 and day 37 or so, okay? This includes the control mice. They start dying first, okay? This is the first death right here, and the second death. The first death in the fasted mice occurs right about here at the time of the second death in the control. And then we quickly get another death in the fasted, et cetera, et cetera. The fasted plus the doxorubicin death, the first one occurs way out here in day 32, okay? And then doxorubicin alone, the first death occurs at day 30, 33 or so. And then when we get down to day 35, almost everybody in the first 3 groups is dead. But look at this. The group that got chemotherapy and were fasted, they get out to day 46. They live 11 days longer. So that means that that means that no matter what you do all 3 of these. You give them no treatment at all, you fast them, or you give them chemotherapy, they all die at the same place. You did nothing, okay? If you fast and combine chemotherapy, you do something. You get a big split here. And what I want to point out is that the fasted alone died at the same rate as the chemotherapy alone. So fasting, you can see that in this case, fasting was not a good treatment for this cancer. It did no better than nothing. Now, this wasn't a cure. These mice didn't go on out there. They all died, but there was an improvement.
10 minutes.
Thank you. And we're almost done here. So Walter Longo is at University of Southern California, and he's one of the major researchers looking into fasting and cancer. And he has put together this particular paradigm that he believes explains why fasting and cancer go together, fasting and chemotherapy go together. And it goes like this. And again, this is, it's a paradigm. It's a story we're telling ourselves about why this must happen until we get a better story. But here's the story today. When starved, normal cells stop growing. Okay? Cancer cells cannot stop growing because they have activating mutations and so on. So when you apply chemotherapy, the normal cells who are not doing much, they're kind of in a dormant state when they're starved, are not as affected by the chemotherapy. Okay? The cancer cells, however, cannot stop. They continue their activities while getting poisoned, and they die. So growing while being poisoned is a bad idea. And he has made these cartoons that explain this, and you'll get this in your handouts, I guess, or from the slides that you're going to be getting. So I won't go too much into that, but basically it's saying the same thing, that short-term starvation protects, this is normal cells, and kills tumor cells. So how about human beings? Has any of this been looked at in humans? Yes. Not a lot, but yes. So Walter Longo at University of Southern California likes to do YouTube videos, and he likes to show little rats running around in cages that all, with their hair falling out from cisplatin. So some of the patients at University of Southern California looked at these videos and came to Longo and said, put us on a fasting program. He said, I can't do that. He said, he's a PhD, he's not a doctor, not an MD. He said, I can't do that. There's no, we can't do that. I said, well, we're going to do it ourselves, and you watch us. So these were 10 patients with different cancers, and they fasted. These guys were animals, okay, fasted 48 to 140 hours, and 56 hours after chemotherapy. So we were talking about, 4, 5, 6, how many, 56, how many hours in a week? I don't know. I think, anyway, a lot. So 140 hours, so some of these patients were fasting a week around each chemotherapy infusion. So the results, the fasting was well tolerated. It was associated with reduced fatigue, weakness, and GI side effects. So these patients had fewer episodes of vomiting. There was no adverse effect on the tumor volume or on serum tumor markers. I mean, the oncologists were freaking out here. They were saying, your cancer's going to grow faster. This is just you're going to die. This is a bad idea. You're going to die if you don't eat for 3 days. None of you think that, right? No. Okay. All right. I've been asking people that. How long do you have to go without food before you die? And the answer is usually 3 to 5 days. Okay, so there was some mild lightheadedness and weakness. So here's what I recommend for my patients at my clinic. Okay, so 24 hours before through 24 hours after the chemotherapy infusion, no food if you can do it. Okay, there's an easier version if they fall on the floor and say, but I will die. So you say, okay, 16 hours before and 8 hours after, and nothing during too. So that's 24 hours. And then the easiest version is 12 hours before and 4 hours after. So that's 16 hours. That freaks people out. So what I have them do is practice before they get to their chemotherapy, and and try it and see. My gosh, I didn't die after 16 hours without.
What would you do though? What would be the ideal that you would? What would you do if it was yourself?
I would do this one, absolutely.
Would you do longer?
We'll talk about that. We don't know. We don't know what the ideal is, and we're going to have to figure out what to measure. So for some other patients, and during one of the answers is that you want to get into ketosis. So what does it take to get into ketosis? For me, it takes about 24 to 30 hours to get into ketosis. So I would have to go a little bit longer than somebody who does not gets into ketosis more quickly. So I like my cancer patients who are on radiation therapy to definitely take an eating window approach. And that means that they are eating from 8 to 12 hours daily. They can pick their 8 to 12 hour window. And I like them to measure their blood ketone levels and try to get so that they're staying in here with a combination of diet and intermittent fasting and smaller eating windows.
What was the 1.6 to 1.8? Is that the ketone level?
Yes, with my little ultra, what's the Precision Extra?
Precision.
Yes, Precision Extra. So, short fasts are good. They're safe, and they're terrifying. And this is what the oncologists will say, and the chemotherapy nurses, and the patient's family members if you suggest that the patient fast who has cancer. Why are they so afraid of it? This is still up. This is still up on the American Cancer. They say they're going to change, and they have changed some of their other literature, but they recommend that cancer patients snack often, and the first food they should eat is angel food cake. And what are they afraid of? They're afraid of this. This is cancer cachexia. And it's an inflammatory syndrome. It's not, if you go away from here knowing nothing else, it's that cancer cachexia is not caused by not eating, okay? You can eat 10,000 calories a day, and if you're going to get cancer cachexia, you will have it because it's an inflammatory process. So does your patient have cancer cachexia if they do not fast them, okay? This is generally a syndrome seen in patients with advanced cancer. It's not seen in patients who have early stage cancer that you're most likely to see, because most patients do have early stage cancer, like early stage breast cancer 1, 2, 3, colon cancer 1, 2, 3, prostate cancer, et cetera. This is the current definition, and this definition is a moving target as we learn more. But the main thing is new weight loss. You notice that weight loss is in all 4 of these. I did that on purpose because that is the main part of cancer cachexia, new weight loss. It's hard to lose weight. I don't know if any of you have noticed that. I have. Oh my God. It's hard to lose weight. If you suddenly easily lose weight, there is something wrong, okay? So another thing that I want you to know is that your patient can be overweight and even obese and still have cancer cachexia. Okay, so who gets cancer cachexia? Patients with end-stage solid tumors, okay? GI cancers, especially upper GI, head and neck cancers, and lung cancers. Cancer cachexia is by definition absent in the adjuvant setting. So if you have someone who comes in and says, I'm getting adjuvant chemotherapy, which means chemotherapy or radiation therapy for cancer that's been removed and there's no sign of it on our scans, that's adjuvant. They don't have cancer cachexia unless you have, weight loss. Okay? If you see weight loss, send them back to the oncologist and say, you need to look at this patient again because there's something else really bad going on. So weight gain is a common problem in patients on adjuvant chemotherapy, especially for breast cancer, not weight loss. So the hallmark of cancer cachexia is not loss of fat, it's loss of muscle. All right? And this is normal muscle, a little bit of fat. This is a cross-section through the thigh here. This is and this is a patient not necessarily with cancer, but just with aging. And you see that the leg diameter is about the same or maybe even a little larger, but there's more fat, this white stuff around the edge. This dark stuff in the middle is muscle. This little black circle with white marrow inside is bone with marrow inside. And I put this slide up just so that you don't think that, and this is directly for you, that aging has anything to do with sarcopenia, okay? This guy is 70 years old. He's a triathlete. This one is a 40-year-old triathlete. This is a 74-year-old sedentary man. I promise you, this could be a 47-year-old sedentary man, and this is what we'd see, okay? So aging is no excuse. You need to not get sarcopenic, okay? And your patients are, I'm not really. Okay. So anyway, so increasing caloric intake doesn't help, okay? So what does help is early recognition and treatment. And again, this is a job for the oncologist. If you suspect your patient has this with weight loss, send them back. What we're trying now are omega-3 fatty acids, COX-2 inhibitors, steroids, cannabis, androgens, resistance exercise. We don't know what works, okay? It's interesting that this does seem to help, though. And there are some emerging therapies. And again, this is a patient with lots of muscle here. This is a patient and not much fat. This white stuff, black stuff around the outside is fat. And this is a patient with very little muscle and lots of fat. So this patient is sarcopenic. Let's see here. I think we're done then.
What was that about strenuous exercise?
Do it. It's good. Not this. Not this. Okay. So that was a slide about androgen deprivation therapy in prostate cancer causes sarcopenia, insulin resistance, obesity. And there are a couple of really nice studies showing that resistance exercise can prevent and even reverse those side effects, even reverses the sexual impotence caused by androgen deprivation therapy. But this is not the thing, okay? This is it, all right? All right, thank you. So questions or?
Yeah, why don't we just have like a few minutes for questions?
If you have something specific, I know there's a prostate cancer slide in there. What did it say?
It says androgen deprivation therapy should go for insulin for high doses of resistance.
All right, but other than that, do you have any comment about diet and prostate therapy?
That's a whole nother talk, and we can talk about that. Yes, I do. I have a big opinion about that. Yes.
I've seen you can order IGF-1 blood levels.
Yes.
So there's that, and then there's IGF-1 receptors. Is there any value?
I'm working very hard. Nobody's testing for this clinically. I'm working very hard. I've got Caris Molecular Intelligence out of Tucson, Arizona, Phoenix, Arizona, right here, who's now saying that they're going to check for mutations, at least, in the IGF-1 receptor. I want them to check for IGF-1 receptor expression in tumors routinely. So we'll get that.
Blood level of IGF-1?
It depends on whether we don't know. It depends on whether the tumor has this receptor. So is the tumor responsive to blood levels of IGF-1 is probably a better question. We don't know that for sure either. My feeling is that you look at the patient, if they have a lot of insulin resistance, if they have a lot of upper body mass and very little lower body mass, those are signs of excess insulin signaling. You want to try to cool that off a little bit and get them more insulin sensitive. Yes?
In your cancer patients that you're having them check their sugars postprandially, and is it the same goal as a diabetic, or are you even more stringent with it?
No, I have, and it depends on the patient's tolerance, because not everybody will tolerate doing this. There's some people who really get into it, and many who don't.
Most of them aren't diabetic, right?
They're not diabetic, at least, or not. They're not diagnosed. I make a lot of diagnoses of diabetes. I must have made 4 last week in patients who come to see me because of cancer, and they're not, having blood sugars of 300 or something, but they're having really consistent morning fasting blood sugars of 110, 120, and postprandially. So my goals are, I give them a goal. I say the fasting blood sugar, I like that. The ideal is between 75 and 85. Now, I'm not saying you need to get to that ideal, but that's your goal. That's your North Star. And postprandially, I love them to be at least less than 140. That's at 2 hours, yes.
That's even strict for diabetics.
It may be. I'm not a diabetes doctor, so I don't really follow that literature that closely. I'm not that interested in it. But yeah. So those are my parameters right now. Those are my North Stars. Yes.
Are there any data on exogenous ketones and the effects of that in cancer?
Not much. So I know that Dom D'Agostino and Seyfried are working on that. And they're working very hard on that. So we should have some in the next few years. Yeah.
And do you have anything to say about a protein, a fast that just takes out carbs and, so some people recommend intermittent fasting but let you have bulletproof coffee in the morning. Mm-hmm. Does that count as a fast in terms of, because it wouldn't generate IGF-1?
I tell patients to hold off on any caloric intake if they're actually going for their chemotherapy or radiation therapy right then. We don't know, and again, that's going to be answered by his question, is just keeping the ketone level enough to get this effect, and we don't know the answer to that yet. So that's those are good questions. Yeah.
You mentioned the slide about lipids being a potential food source, fuel source for cancer. So could you talk about that?
Sure. Cancers are so protein, and every cancer is different than, you can have 2 patients with breast cancer, and they each have completely different diseases. There are, at least 8 and growing subtypes of breast cancer that I can think of right off. And then if you look at a patient's tumor longitudinally over time, so for instance, if their tumor might not express or might express hormone receptors at the very beginning of their diagnosis, but if you check it again in 5 years and they have metastases, you check those metastases, they might not express hormone receptors. We haven't even started looking at how the tumors change over time within one patient. So, one of the takeaways from this is that any dietary intervention is liable to have, in my opinion, based on previous what's gone on in oncology, is liable to have a temporary effect. The tumor's likely to adjust in some way and go around that, because tumors are very complex and they have a lot of tricks up their sleeve. So, but the main thing about this is that if you do this intervention during treatment, you can really potentiate the effects of treatment.
Let's do one more question and we'll wrap up.
Do you accept that the micronutrients such as sulforaphanes help prevent cancer or decrease the risk of cancer?
They do in certain patients, and there have been some very nice studies that show that whether you're going to have your cancer prevented by sulforaphanes depends on your genome. So some patients do and some patients don't. And
We'll talk about that this afternoon.
Sulforaphanes across the board as a cancer preventive, no. Sometimes, yes. But the take home about this is that looking at micronutrient profiles and things like that has been very disappointing in cancer. And now we're starting to see some bigger pictures with macronutrients and caloric restriction that have really large, indisputable effects, not these piddly little iffy effects that come and go depending on the study. So, okay, thank you.